well. And thank you. I know you're very busy, so this is really, really appreciated. So got all my little questions and notes here, so we'll crack on so that I'm not keeping you all day. So yeah, and also apologies. This is not menopausal sweat. I don't think so. I've got one of this cold that's going around, so I feel like I'm on the verge of a sneeze every year. So I've had a few questions. A lot of the people that I teach now, because I've been teaching for quite some time, obviously I feel like you kind of attract the same kind of age range that you are, and so obviously I used to teach people in my 20s, and I'm not in my 20s anymore, and a lot of the women that I teach are either perimenopausal, menopausal, postmenopausal. So I think just to bring it back to the very basics of that, because I think there's still a lot of confusion with actually what is menopause. So, where does it start?
Yeah. So menopause, if you look at the definition, it's a funny definition because it's a retrospective diagnosis. Mm-hmm. So it's 1 year after your last menstrual period. Mm-hmm. So that's not a bleed that you've had on any hormone treatment or anything. It's your last menstrual period. And it's almost like a moment in time. Mm-hmm. It's like suddenly you're in the menopause 1 year after your last period. So it's a strange diagnosis. And the other misconception is that you go into the menopause and you come out of it, but you don't. You just go into it and you stay there, because menopause means your ovaries aren't producing estrogen anymore, and you are never going to start producing that estrogen again. So it's you go into the menopause and you stay there. So there's not a matter of
post-menopause. It is just all the same. Menopause, post-menopause, it is just the same thing, isn't it?
It is really. And the post makes it feel like you've come out of it somehow, but actually you don't. You're in that estrogen deficient state for the rest of your life, and that time can be now, because luckily as women we're living way into our 80s on average. It can be half to a third of our lives. So it's a lot of time to be living and trying to function well in an estrogen deficient state.
That's it. And I think that's a misconception of a lot of the women that I teach have said to me, oh, it doesn't apply to me now because I've gone through it. And I've tried to explain in the best way that I can that if it's happened, if that menopausal stage has happened, that's just carrying on. So all the symptoms that you had on that run up, you can still continue to have them and have treatment for them.
Yes, absolutely. Yes. And the other important thing about the menopause, which I always think of, I know it's got a sort of a bad rep and it feels like it's all doom and gloom, but also you can sort of think of it as an opportunity, because it's the time when these symptoms might start to occur, which aren't very pleasant, but it's also like an alarm bell for us women to say our health risks also start to increase at that time, which is often in midlife. So our risk of heart disease starts to climb, our bones start to thin, and it's also a time that we potentially build up some plaques on our brains, which can then lead to dementia and Alzheimer's. Our risk of type 2 diabetes and osteoarthritis, and all these things start to climb in our midlife. So almost as although the symptoms are not good, obviously, it's almost like a little alarm bell to us women to say, look, things are changing, and you can do something about it. If you do something about it when you start noticing the change, when it starts to happen, you can actually do things to prevent those long-term health problems that can arise. So it's actually a little bit of a sort of an opportunity and not just all doom and gloom. I try to sort of reframe it a little bit. Doom and gloom.
And those symptoms are vast, aren't they? So you've got the kind of, I think what everybody associates menopause, think kind of hot flushes, and some women think that is it, and they don't realise that the other things that's happening to them is actually related to their menopausal symptoms. Again, a lot of women that I know, anxiety, I think, is possibly the biggest one that I've spoken to people, especially with what I do as well. So, and I know personally, I feel just irrational anxiety, especially when you're trying to get to sleep at night, which I guess is a time for everyone to feel a bit anxious about things. But yeah, it's definitely was a symptom for me. But So anxiety, a little bit of mood swings, obviously the hot flushes. I personally had a lot of breast tenderness, very hormonal, but when you don't actually get much of a let up in your hormonal cycle, when you're thinking it's the build up to your period and the ovulation where I was getting those breast pain, it's quite concerning, but so many other things as well, isn't there? I don't know.
So many things, because as women, estrogen is like our master regulator. It's one of our main sources of energy, really, from the tops of our heads to the tips of our toes. So in terms of the physical symptoms, most of us know about the hot sweats and night and flushes, but then there's the joint pains and muscle aches, which can be very problematic. Migraines can start to become more into the picture. There's dry mouth, dry eyes, itchy skin. There's formication, which is the feeling of almost like insects crawling under your skin, which is a really horrible one. Some people get tinnitus.
I was supposed to mention that, yeah. So, what a crazy...
I know. It just sounds nuts, but I think it's because our bodies are so sensitive and receptive to estrogen that when the estrogen drops down, all of our cells start to struggle. So there's a physical symptoms, and then you rightfully pointed out the psychological mental health symptoms, which are, like you say, often are the first things to come into the picture in the perimenopause. So the anxiety can creep in insidiously, and it's sort of, for some women, it's that background feeling of just being ill at ease and every day feeling there's something to be worried about, but actually there isn't anything to worry about. And it can extend to a point where some women get worried about driving or doing certain tasks that previously they never really thought about, and suddenly they're starting to get anxious about it, and it can then lead on to full-blown panic and panic attacks. And it's often the first thing that people notice in the perimenopause, when the cycles start to change slightly. But because it's perimenopause and because it is variable, because in the perimenopause our estrogen goes up and down, the symptoms thus do go also up and down. So trying to pinpoint it to it being hormonal, because often a woman will think, well, I probably felt anxious that day because of this or that or this, but actually, and they won't necessarily realise it's the hormones, because maybe the next week they don't feel so bad. So it's quite difficult to join the dots up.
I have one client that she's a friend as well, but she talks about the rage. She suffers from rage, and she just feels, and she's very young as well, actually, so she's very much in that perimenopause. But again, it can start from a very young age, can't it, really? She's just saying that she just has this irrational rage that she can't, she can't rationalise, and I think it is very much down to the same as you would with PMT, I guess. It's still a hormonal,
Definitely hormonal, definitely. And that rage is really awful because you can't help it. No. This sort of red mist suddenly drops in front of your eyes, and before you know it, you go from a relatively calm place to just going completely through the ceiling.
Yeah. And then the anxiety kicks in, and you end up crying your eyes out. And
and there's the guilt. There's the guilt. And then you feel terrible about who's received that rage that you've just exactly. You feel then bad about yourself, and then you start losing a sense of yourself because you think, hang on, who is this person who says these things and does these things? I never used to do this. But it's all part of the psychological symptoms which are very important to be aware of in the perimenopause and menopause, because our brains are so receptive, as I said before, about from estrogen. So the rage is part of that, and mood swings and low mood, and some women even get to the point where they feel suicidal. It's dreadful, tragic.
It often gets misdiagnosed, doesn't it, as depression and anxiety, and go down the kind of route of antidepressants, which I'm not saying are a bad thing at all, which will suit some people, but sometimes that's not what they need, is it? It's actually what's going on hormonally.
I think if it's a new thing for a woman and it's something that they've not experienced before, and they're getting to this midlife stage and they're getting anxiety and low mood, and often actually, if you ask women, they often sort of will say, I don't think I'm depressed. They kind of know, and even if they've had depression, anxiety in the past, they will know it feels a bit different. And they know it's not that they need to up their antidepressants, it's that they actually need something different. Women can be, if we listen to ourselves and our bodies, we can be quite intuitive. And I think it's so important to listen to that, because it is the key really to recognising what's going on.
And I think that especially recently, say within the last, I mean, maybe it's just because I'm in that perimenopause, so I've been doing more research, obviously teaching more people, been doing a lot more research. But there seems to be a lot more out there, especially recently, obviously with the whole prescription that got passed a couple of weeks ago, but on social media. And I know that one of the reasons why I'm doing this is because not everybody that I teach are on social media, or they don't follow those particular accounts. But there's some great that's one thing that actually social media is really good for, I find at the moment. There are some absolute great accounts that have great information and make you feel like, oh, yeah, that's me, kind of, when people like, I know Lisa Snowden does the menopause care chats on lives, and Davina McCall obviously has done the television program. So it's great that it's getting talked about more and more. But I still feel like there's lots that is missing, a whole group of women that they don't know about, that there is actually help that out there if they want it. Yesterday I was teaching, and it's not always very often someone will come over to me and say I'm having I'm going through the menopause, I'm perimenopausal, but she did say that she's just having the most bizarre hot flushes. And I suggested HRT. I said, have you thought about that? Have you looked into that? She's just, no, she hadn't. It's not something that that she'd given any thought to whatsoever. And I think it's something that still frightens a lot of people. So with all those symptoms, there is something, or there are lots of different things that you can do, but HRT is obviously one route that is
to definitely consider. The vast majority of women, for them, the benefits will outweigh any risks with HRT. So it's definitely something to explore and discuss with your healthcare provider. And because if the underlying cause is the low estrogen, replacing that is going to be the treatment. That's going to get the outcome that you want. But it's really important, as I say, in midlife, also to consider your lifestyle. Yes. That is really very important as well, because really you can sit on the sofa, have cigarettes and drink lots of wine, be on your HRT, but you're not going to feel that much better, really, and you're not going to have a healthier, long life by just doing that. You've got to add in the lifestyle, which is your exercise. I mean, if you prescribe exercise, the long-term health outcomes and the mental health and physical health benefits are just so huge. We know this from studies from years and years and years. Good nutrition, low stress, good sleep, not drinking too much alcohol, and these sort of lifestyle things, which can make a massive difference.
I guess it's a vicious cycle in a way, because a lot of women, me included, get a bit stressed, have a glass of wine, then we don't sleep, and then the anxiety starts, and then it all just keeps, going round and round. So yeah, it's looking at it as a whole, isn't it?
It's definitely, yeah, absolutely.
So for me, I was first of all, I was prescribed estrogen. Well, I'm still on the estrogen, so I decided to go down the HRT route just to see. The brain fog for me was also a big thing. So it's breast tenderness, brain fog, hot sweats, which I'm still getting a bit of. So I was having the estrogen and the progesterone tablets of an evening. I was rubbish at taking those, because I know you only take them for 12 days. So we've switched to the coil. So I'm about 2 months into that. So I think it's all still a bit up and down whilst all of that settles at the moment. So there's estrogen, there's different forms of that, isn't there? So I, as I say, take the gel, but there's patches.
Yeah. So I mean, there's tablets and there's patches, gel and spray. And really the gold standard is estrogen that you have through the skin, because if you look at the molecular structure of those estrogens, they're called body identical, so they have the same structure as the estrogen that you naturally produce from your own ovaries when they were working efficiently. So then you're just matching up and replacing like for like. So it's the most natural type. It's derived plant-based from the root vegetable yams, which is incredible, really, to think that. We never run out of yams.
There used to be very different form. Was it something to do with horses? Years ago.
Yeah, Premarin was from pregnant horses' mare's urine. Yeah.
Nice. Yeah. So it's not that anymore.
Still get the Premarin. You can still get a nice, there are still women on that who were started on it maybe a little while ago, but it is overall considered a bit more old-fashioned. And having the estrogen through the skin means you have no increased risk of clots, which actually, if you have tablet form estrogen, it does increase your risk of clots. Potentially. So that's the main advantage of it. And it goes directly into your bloodstream. So it's not metabolized by the liver. And it's the metabolism of the liver, if you take it orally, which makes the clotting increase, the risk of clotting increase. So there's the gel like you're having, and there's a spray called Lenzetto spray, which you use every day. So the gel and the spray you use on a daily basis.
And they're essentially the same. It's just a different way to take. Yeah.
Absolutely, yeah, different way to take it, and it just suits some women more than others. Everybody absorbs the estrogen through the skin slightly differently, and it's a little bit unpredictable, but it's to do with age, skin type, metabolism, and some things we don't really understand. Some people absorb better from one formulation than another. You can't, it's unpredictable, to be honest, and sometimes we just go with one thing and see what happens. But then there's the patches as well. The patches are a bit different. You change those twice a week. So that each patch lasts about 3 to 4 days, and you just change them. So, it really is. Some women will say to me, oh, I don't like the idea of having a patch. I get eczema or whatever, and we'll say, fine, we'll try something else. And initially I just go with whatever that woman feels is right for them, and what they believe is the best for them, and what works for their lifestyle, really.
Personal preference, as I say, that taking because you can have. You can be on the coil, can't you? But you can't have estrogen without progesterone. Is that right? You have to have some form of progesterone if you're on an estrogen or any of the estrogen
replacement.
Yes.
Yeah. So you only need progesterone if you have a womb.
Right. Oh, okay. Yes. Yeah.
But if you've had a hysterectomy, which takes out your womb and your cervix, then you don't need progesterone, because the role of progesterone in HRT is to ensure the lining of the womb doesn't get too thick. Mm-hmm. Because what the studies have shown is that if a woman has a womb and they have estrogen alone without the progesterone, there is a risk of the lining of the womb getting thicker and thicker and thicker. And over a period of years, some of those cells can change into atypical cells and then potentially can go on to cancer.
Right.
So, but we know from the studies, to avoid that, we add in the progesterone to make sure that overgrowth doesn't occur. So the progesterone that you said you had originally is, again, the body identical natural progesterone, also derived from yams, funnily enough. And that is, again, replacing your hormones like for like. But the Mirena coil also is a brilliant way of protecting the womb lining, because it works very locally, has minimal absorption into your main bloodstream, and then you can forget about it because it will work as part of your HRT regime for up to 5 years. So if it works
for me, it was just work. It was just because I am just hopeless at remembering to take tablets, so it just worked with me better. But I know that the tablets also have a slight sedative effect, don't they? So
yeah, I mean, for some women, not for all.
Yeah, I didn't find it was too much, but they said that it could have help with sleep a little.
Some women is really helpful with sleep, which is why we always say have it at night time, because you don't want to be sleepy in the day. It does make you feel sedated. And have it on an empty stomach, we always say, because if you've got food in your stomach, if anything, it works a little bit more strongly. But it can help with sleep, but not for everybody. So it's rare, it's unusual to have a woman on progesterone just to help with sleep if they haven't got a womb. Right. It is that body identical progesterone. Again, it is sort of the gold standard one, but sometimes we need to move beyond that one, because some people get bleeding on that particular type of progesterone, and there are lots of other options as well, and the coil is a fantastic option.
So it's just finding what works for you, your lifestyle.
Definitely.
Yeah.
And it has to be tailored for that individual person, and nobody's symptoms or life or beliefs or lifestyle is the same. But there's always going to be an option for anybody working towards all those issues. So
it's just finding the balance to readdress the balance, I guess, with all of those. And then obviously there's testosterone. Which, I didn't realise that we produced as much testosterone naturally as what we do. I mean, it is the misconception that it is more of a male hormone. Yeah, which I'm having, going for bloods not till January, because I do still feel that with all of what I'm having, it still needs to be tweaked a little bit maybe, and that just to check, because my energy levels haven't come quite back up with the estrogen. So we're going to just do a few bloods for testosterone. So testosterone is not licensed, is it, on the NHS as yet?
No.
Which is
yeah. It's a tricky one, testosterone. And you're right, you're in the majority. Most people don't realise that women actually produce any testosterone at all. But before the menopause, we produce 3 times more testosterone than we do actually estrogen, which is a crazy thing to think of, but it's true. And then as we enter the sort of in our 40s, it does start to drop down. If we have a surgical menopause where our ovaries are removed, our testosterone is then reduced down very dramatically. But we produce roughly 50% of our testosterone from our ovaries, but we do get 50% roughly from our adrenal glands, which are the glands that sit just above our kidneys. So it's a really important hormone. It's always linked with libido, and it is important for libido, and low libido is a big problem for many of the ladies I see in my clinic. But it isn't just libido, it also helps with cognitive functioning, so that brain fog, multitasking, memory. It also helps with muscle mass, stamina, drive, feelings of joy, does seem to possibly have some benefit in terms of bone health as well. So I mean, overall, if you look at the general guidance, it says it's for libido, but we do know in the specialist menopause world, we know women benefit in other ways from it as well. But you're right, it isn't licensed at the moment in the UK for women. We only have a male form licensed in the UK. So men can get their testosterone, but we can't get testosterone.
It's incredibly
very unfair.
Yeah.
So it is tricky to get hold of it. We do have, we can import something called androfem, which is a form of testosterone cream, which is licensed in Australia. So that's a good step in the right direction. And our regulatory bodies allow us to import it and prescribe it in the UK to women, but it's only available in the private sector currently. I know there is work being done to try and get it onto the NHS formularies so that it can be prescribed in the NHS, but we're not there yet. I think we're some years away from that, unfortunately.
Okay. And is it a case of the more women talk to their doctors about it, the more likelihood it's going to push it forwards?
I think it's going to help, but I know that there's specialists are actually working directly with the government, etc., trying to get this pushed through, but things don't happen that quickly, as we all know. So in the meantime, as I say, there is the androfem privately. It is a cost, it costs about 80 pence a day.
Right.
But it is a nice, easy formulation for women to use. But there is also the male form that us as women, we can use the male form. It is effectively the same thing. We just need a much lower dose. So the male forms that we have available on the NHS and in the UK are very strong for women. It's a very potent dose for women. Yeah. So we have to give we need a lot less, about a tenth of that actually. Yeah. So we need to take a tiny little amount of the male formulation, which is doable. It's just a little bit more fiddly, a little bit more tricky to get an accurate dosing, but not impossible.
Yeah,
so it can,
it's
an option. Yeah. And testosterone, it's not as though it's not safe for women. We've got data to show that it's safe to use and it is effective. In fact, there was a patch that was available for women several years back. The only reason it stopped being made was because people weren't prescribing it, because of the lack of awareness within the medical world that actually it was something that women would benefit from. So it was purely commercial reasons, not safety reasons, that it went off the formulary. And there used to be even a testosterone, it was a implant that women had after hysterectomy and after have their ovaries removed. But again, they stopped using that because it seemed it was almost a bit too strong. But So testosterone in women, I'm hoping the awareness is going to increase, because it is so important. Not everybody needs it, but for some women, it is an absolute game changer. It is important, like you said before, Julia, to get your estrogen levels ideally right first, because sometimes the estrogen will deal with things like libido and all the other brain and muscle strength, that sort of thing as well. But for some women, they do need to then move on to testosterone, and can make a huge difference. I mean, really life-changing difference.
And it's really good that all of these things can be tweaked along the way, like with the estrogen, especially with the pump. I find that very easy to manage, where you start on one, 2 pumps, and then see how you go with that, and then you can change it around. So it's for me, it's been brilliant. As I say, I still need to tweak it a bit more, but it'll be ongoing for a while. So
that's normal, to have that tweaking. It's not so often that we get it right straight off on initial, and no one fits all at all.
I can say it's not one tablet fits everyone. No.
And also in the perimenopause, because you'll be having some sort of menstrual cycle, and some sort of hormones will be produced in the perimenopause. It's always going to be a slightly changing environment, because your hormone requirement is going to change going forward. So no matter what hormone regime you get settled on, I'd always suggest an annual review at least, to make sure there's no new tweaks that need to be occurring, because as we get older, it will change, our requirement will change. So it's always
you're constantly fighting it against that decline all the time, and if it just keeps declining, you have to just keep taking different measures to bring it up.
Yeah, that's it.
And obviously a lot of women on HRT, they associate HRT immediately with risks and breast cancer, which I know is more the kind of the risks of yesteryear, but there is still a lot of misinformation out there, isn't there, about the risks of breast cancer?
There is a lot of it. And we do emphasize a lot about breast cancer, don't we? And HRT. Yeah. And the difficulty is, I think it feels like it's become a very magnified issue, and we forget to think about all the other health benefits and weighing it all up. So breast cancer and HRT, we know that estrogen is not a carcinogenic. We know that estrogen can't change a normal cell into a cancer cell. Right. So it isn't a carcinogenic, and it is a complex picture. We still, in truth, probably don't really understand everything about breast cancer. Yeah. And there's nothing to prove that HRT causes or leads to an increased risk of breast cancer, or doesn't. The very fact that it's still a question mark out there in itself shows that probably the link is not going to be very strong. Yeah. And I think we always have to be aware that HRT reduced your risk of heart disease by up to 50%.
Which is incredible.
Which is incredible, because actually heart disease is the biggest killer, or the second biggest killer of women in this country. Right. There's growing evidence, but not sort of absolutely certain, but there's growing evidence that seems to have some protection against brain disorders, dementia and Alzheimer's. And that is the biggest killer of women in this country. Right. And then it also protects against bone thinning and fractures. We know over the age of 50, maybe even half women have some sort of bone thinning, and then a third will go on to have a hip fracture, which then leads to hospitalization. After a hip fracture, actually, there's a high proportion of women that die within a year after a hip fracture. So these are big things that HRT will protect against, or reduce your risk against, I should say. Also reduces your risk of type 2 diabetes, osteoarthritis. And there is a study that shows that it seems to have some protection against even bowel cancer. So a lot of health protection, a lot of, obviously HRT gives quality of life. So like you rightfully said before, Julia, if you're feeling rotten, if you're feeling you aren't getting sleep, and you're feeling low, and all those other symptoms of the possible menopause, and you end up drinking more, or you end up not exercising because your joints hurt so much and it's so much of an effort, or you end up eating less well and putting on weight because you're comfort eating, or and you get into that cycle of bad, not bad, but not so healthy lifestyle. But then you put women on HRT, they feel better, they start exercising because their joint pains go away. Yes. Their minds are working better, so they start addressing and looking at their diet. They start looking at their lifestyle, and that, as I said to you before, the health benefits of exercise, not being obese, not drinking too much, not smoking, are humongous. Yeah. So as a secondary benefit, HRT does that as well. So massive health benefits and quality of life benefits. In terms of breast cancer, if you look at the statistics, and if you put all the HRTs together, so if you include all the old-fashioned old ones, like the horses, mare's urine, tablet form HRT, and the modern HRT, if you bundle all in one group, what they will say is if you follow 1,000 women over a year, and they are some on HRT and some aren't, and they're aged between 50 and 59. Over that 5 years, over 5 years, an extra 4 women will develop breast cancer versus those that weren't on a HRT. Yeah, okay. So you're talking about less than 1 extra woman per year. Now, don't get me wrong, that less than 1 extra woman per year is still significant, but on the greater scheme of the other health benefits and etc., then it is relatively minor, obviously not for that person. And also what we do know is that there's studies on the new modern body identical HRT. There are studies to show that is much more breast friendly, and actually the risk for that is less, at least for the first 5 years. And after that, it is so small. And what we do know is there's no increased risk of dying with breast cancer if you're on HRT, no matter what HRT you're on, whether you're on the old one or the more modern one. Right. But not all HRT is equal in terms of being breast friendly. And we do know that the body identical modern HRT appears to be safer in terms of breast. If you don't have a womb and all you need is estrogen, actually you have a reduced risk of breast cancer. Okay. So it seems to be the adding in of a synthetic type of progestogen, but we still don't understand it completely. We need more studies, but needless to say, it is a minor, tiny risk weighing against all the potential pros. Yeah. So I think it's become out of context. That's the problem with it.
I think that is the problem. I think it's always going to be that question because it always seemed to be such a prevalent question years ago. It's always been on people's minds, and it is one thing that unfortunately is stopping people from going down the route of HRT, which is a shame, really. Because
such a shame.
Yeah. On a whole, as you say, it's a woman can decide not to take HRT but sit on a sofa and smoke and drink, which is going to increase your risk of all the cancers, really. So it's about just having a kind of rational look into it, I guess.
It's balancing everything up and look at the bigger picture.
Sure. And another question, which again I'm guessing it's probably too big, and feel free if it's not kind of one that you want to go too deep into, but I have somebody that has dementia, and she's in her 60s. She's a very vibrant lady in her 60s, and obviously that kind of memory loss is kind of kicking in now. Obviously she's gone through the menopause, or she's still in that kind of menopausal stage in her 60s. Can you take, and I don't want to advocate HRT is a cure for dementia at all, but can you take HRT if you are suffering with dementia? Is that something that you'd ever recommend?
So with HRT and the health benefits that I just have mentioned to you, the many health benefits, the key with it is the timing when you take it. And we in the medical world, we call it a window of opportunity. Yeah. And generally that is on average before you're 60 or within 10 years of your menopause.
Sure.
Because the thing with estrogen and HRT replacement is it, apart from with your bones, actually it can treat and build up your bones very well. And apart from that, mostly it is a prevention rather than going to help it in a disease once it's established.
Yeah.
So in terms of things like heart disease and dementia, once it's established, it's not going to have any benefit.
Right. Okay.
In terms of reducing your risk going forwards.
But with all those other aspects, as far as all the benefits, would that still be recommended? It wouldn't be harmful for her to go on HRT, or?
So do you know, it's very difficult. There are studies with HRT and dementia, and there's mixed data. None of the studies actually out there are really brilliant. And there's some which will say that if you take HRT later in life, there is a possibly increased risk of dementia.
Okay, right, okay.
And others that will say that's not true. This study found something different.
It's a lot that I read that's very much a preventative of,
it's that. So once it's, because what we know with dementia and Alzheimer's, it's plaque deposition on the brain cells. And it's a build-up of these plaques. And it's what the science is showing is that actually it seems to start, I don't want to scare anybody, but the build-up of the plaques seems to start 20 years up to before the symptoms actually start to arise. So if estrogen is going to have any sort of prevention, it needs to be starting earlier
rather than later.
Having said that, there might be, for somebody like the lady with dementia, it depends really on what her personal aims and goals are in terms of HRT, and what else, it's not, it would be very much an individual discussion with her. What I would say is, if you've got dementia, it depends on how well you can weigh up the information. Because the problem with dementia is that it might affect your ability to weigh up that information, and therefore being able to make an informed decision on something which is quite complex might prove to be a bit challenging. But I would say, I would never say to anybody, you are not allowed to have HRT, you cannot have. It's always a personal decision, and it's a joint decision between your healthcare professional and you as an individual. And it's about weighing up the pros and cons for you personally. It's not just the pros and cons of having the HRT, but it's also the health benefits you might not get if you don't have HRT. So, and we all have a very personal idea of risk, don't we? Some of us will do bungee jumping and some of us won't. and that's, no, I won't do it. But in terms of, our sense of risk.
Sure.
And if your mum had a terrible hip fracture and had osteoporosis, for you, your main thing might be actually, I want to prevent osteoporosis. Everybody's perspective is very personal. And I'd always say an individual discussion with somebody who can tell you the pros and cons and the studies which we have and the evidence we have is the best way forwards.
Sure. So if you opposed to HRT, or you're too scared of HRT, obviously I did the chat with Emma Ellis-Flint, so talking about nutrition, which she's very much of using it alongside HRT, which is great, but there are those that don't want to take HRT or for whatever reasons they've been advised not to. Are there any natural remedies? And I'm always a bit cautious about this, especially in my yoga world. There's a lot of nonsense that goes along with it, but I do know that there are some variations of natural remedies like St John's wort and things like that for brain function. Would you ever recommend anything natural? Well, I know the estrogen is actually plant-based, so essentially it is a natural remedy, but
it's not really, because it's just you're replacing your own hormone. Really. I understand what you're saying.
I think over the counter,
over the counter type stuff. So if you don't want to take HRT, there is, and if you've got hot flushes, there are other prescribable medications that you can try to see if it will help your hot flushes. They're not as good as HRT, but some women really find them beneficial. So you can still go to a doctor, so I'm getting hot flushes. So in terms of the natural remedies, it really depends on what symptoms you're trying to address. There are some things like black cohosh and femel, which is a pollen type based derivative, that can help with the hot flushes. The evidence isn't brilliant, I have to confess, for any of the natural ones. If you look at the studies, they don't really perform much better than a placebo, generally on the whole. St. John's wort has been shown to help with mood as well. But unfortunately, the difficulty with St. John's wort is it tends to have an interaction with lots of other medication, which can be problematic. So again, you just have to be careful on what else the other person is taking. So in terms of the herbal remedies, there isn't much which actually shows it does an awful lot.
Again, there's a lot of misinformation out there, I find, that can be very confusing, and also not knowing the dosages, and also some of these over-the-counter kind of vitamins or supplements aren't regulated at all, so you don't even know if there's anything in there of what they're saying on the bottle. So you've got to be really careful, haven't you? Just rely. I mean, if it works as a placebo, perhaps.
I agree, Julia. If it works and it's not costing you too much money, then I'm all for it. If it's not doing any harm and it works and it's not costing you too much money, then actually go for it. If that suits you, that's brilliant. But it's just the evidence behind them isn't fantastic. But you know, there is good evidence for CBT. And a little bit of evidence for things like acupuncture. And I would always emphasize the health side of things. So the exercise, the movement, the relaxation, and the nutrition, like Emma said, you know, all those things are so important. Things like even keeping connected with your friends and a good social life, all these things add to your quality of life and your ability to cope and manage the symptoms.
And just talking about it with other people that are going through it and not, you know, being, you know, I don't know, ashamed of it. It's just we're all going through it. And I guess, like I was saying yesterday in my class, that we didn't ever used to get to that age of menopause. That's why there wasn't any the research many moons ago, because we didn't make it to that age. But as you said, we're all living, well, touch wood, we're all living a lot longer. So that's why you've got to kind of look into having quality of life for possibly half your life or even more.
Absolutely. I think 100 years ago, women were going through the menopause a bit later because the way they were having babies and things were different, and then they died not long after, unfortunately. We're living for longer as women, and we fought very hard, I think, to get equality in the workplace and in other parts of our lives. So now a lot of us are in high-powered jobs. We're working well, we're in big positions professionally, and actually rightfully we expect a good quality of life out of the workplace as well. But then we try and do all these things, and then suddenly we're flawed when our hormones start to drop off, and you just can't. It's hard to battle against that without trying to address it more head on.
And we would take things for other illnesses or whatever to readdress any kind of deficiency or anything else like that. So it makes sense just to
So if you a low thyroid, if you've got a hypothyroid, I don't think anybody would say, no, thank you. I'll just crack on and try and manage without it. And if you have diabetes, I just don't think people would say, I don't want to have my insulin. Thank you very much. The injections hurt, and I just can't see that really being the case. So you rightly said, Juliet, these discussions, chatting about things openly, hopefully will help women being more informed, break the taboos, break myths, and then we can realise there is another way forwards. And it doesn't have to be HRT. It doesn't, there are other options as well.
Changing lifestyle, a few lifestyle changes can be really helpful for people. And on that, I have one question with the alcohol. Does alcohol negate or cancel out any kind of hormone replacement? If you are having a couple of glasses of wine a night and having HRT, is that one thing is kind of cancelling out the other?
In terms of symptoms or health-wise?
Both really. Is it, because I know with the sleep it's going to, let's go with health-wise. Is it going to stop your symptom or stop HRT helping your symptoms if you're drinking a glass of wine every night?
What we do know, in terms of the whole breast fat cancer thing, again, if you're having a large glass of wine a night, which is at home, we know that's probably is about 2 units. You are increasing your breast cancer risk, definitely.
Yes.
But in terms of the whole matching with the HRT? No, is the bottom line. No, you're not cancelling out. We know that wine can, because some women, it can disrupt their sleep, it can make the hot flushes worse.
Yeah.
So it can have those impacts, but not for everybody. Everybody's very different. But no, you can do both, and we can't all be saints. We have to enjoy life, don't we?
That's true. Well, not every night, just overnight, a little tip.
No.
You don't want to think that you're doing all these lifestyle changes and your HRT and it's all kind of going out the window with a glass of wine, or whatever anybody's lifestyle choice is, but still it's all about balance, isn't it?
It's all about balance, absolutely. And at the end of the day, we've got to enjoy our lives, and we as individuals, I think it's all about us as individuals understanding the information, understanding the evidence base, and then we can make a decision ourselves what we want to do with that information. Nobody should be telling you what you should be doing. It's about you knowing what the pros and cons and of everything, and then you decide how you want to move forward. But the bottom line is, no, it does not cancel out the HRT in terms of symptoms and other benefits.
And as far as contacting you, can people contact you directly through the clinic? And do you have to come into clinic, or it's all you can do online consultation?
We're all doing online consultations. It just is easy to access, because we access women from all over the UK, which is really lovely. And it's just convenient. It's very convenient for patients. They don't have to get in the car and travel. And at the moment, there's still a lot of COVID issues around. So it's just convenient and easy. So it's all video consultations. I think Naomi's seeing a few people face to face now. So I work with Dr. Naomi Potter, and our website is menopausecare.co.uk, and there's 12 of us specialist doctors now. So we work in the specialist group, and we see women online, and women book in with us via our website. And it's fabulous. It's been wonderful being able to do it this way and getting the access to so many different women from all over the country.
Was it online before COVID, or is it all happened? It's all
COVID, yeah.
Which is there's not many benefits of it, but this is one, isn't it? That you can reach so many more people now. Yeah. Which is great. Yeah.
It is really good, and I think everybody's feeling a bit more comfortable with the whole IT as well.
Yeah. No one knew Zoom before.
No, I know.
Whatever, your Teams or whatever.
Yeah, actually, we use a special health link for our consultation. It's very secure and confidential. Yeah. You don't want any invaders like you can get when you have a Zoom.
Right. Okay. Yeah.
But yeah, so it's a secure special health consultation link that we use.
Yeah, so I'll put all the links in to yourself and to Naomi, who's also, I love watching her live. She's, they're really informative. I think so many people that are watching these lives at the moment are just, as you say, the knowledge that you're accessing just by, and all the questions that come in that, oh, that's me, or I suffer from that, or I've got that. I didn't even relate it to the menopause at all. So it's really good. It's really getting out there to a lot of people. Not all, though, I have noticed. Still is getting there, slowly.
We're not doing it social media at all.
And obviously, if you are on Instagram with the algorithms and what have you, it's pushing, if you're following people, it's pushing people. So for me, I just think, wow, there's loads of information out there. But for people that either aren't on Instagram or are, and they're not following that demographic or that algorithm,
they're in the dark. They're still in the dark. It's dreadful, really.
And we are half the population, and we are all going to go through it. So it's really important to
it's so important. When you think of it and you put it that way, you think it's so crazy that it's taken till now for it to be really raised at a main.
And for the things like testosterone not being available and things like that, it's kind of like it's very antiquated system that we live in, but we're getting there slowly. Right, I shall leave you to your day now. Thank you so much.
That's helpful. I hope that
it's so helpful and so interesting, and I think really great. Really
great. It's fantastic what you're doing. I think I always applaud anybody who's trying to get the message out there. think once you know, you sort of, there's two camps, like once you know, you know.
Thanks so much for making time. Yeah, we appreciate it. Have a lovely weekend.
Love your dress. Is it a dress?
Oh, it is a dress. Yeah, thank you. Yeah, we're kind of matching a pattern, autumnal pattern. Thank you so much. Thank you. Take care. Bye.